Okay, then let's bring us to a discussion of the serous membranes. Let's go to that before we then go forward into the lungs themselves. Because the serous membrane system is a very interesting system. As organs grow, like as the heart grows, as the lung grows, they sort of grow into a balloon-shaped membrane system like here, like the fist going into the balloon. Because we need to have an ability to separate organs from the muscular and the skeletal walls. Like we need to be able to separate the lungs on the inside from the chest wall on the outside. Because when we breathe, when we move around, we want to have the ability to have these organs glide on the inside without having any friction against a chest wall or an abdomen wall. We have that stuff in the thoracic cavity as well as in the pelvic cavity. I mean the abdominal cavity, in the chest, the heart, and then the abdomen. So these membranes are in the pleural cavity, in the pericardial cavity, in the abdomen area. We call that the peritoneal cavity. So this membrane, since it's originally starts as like we push a fist into a balloon, is two membranes that go against one another. One membrane is right around the organ, and the other membrane is around the wall. Like here's the chest wall in our situation. And those two membranes, on the inside of those two membranes, we have epithelial cells, and the epithelial cells, they secrete a fluid. It's called the serous fluid, since it's the serous membrane system, the way we call that. And that fluid lets those two membranes nicely glide past one another. And so that is a really interesting system. So it's kind of a closed system. It's like, it's not two membranes really, it's really one membrane that wraps around the organ first and then around the chest wall. But it's fully connected all around. And so the serous membrane system is continuous of membranes that either attach, here in the text, to the body wall, and that membrane, we call that the parietal part of the membrane, or it attaches to the organ, and that part is called the visceral part of the membrane. And the epithelial layer on the inside secretes a serous fluid into that cavity, that space, that's between those two membrane layers, and that permits an extensive exchange of movement around those organs without any friction. That's a little bit complicated, but once you get it, it's good, because in the lungs particularly, in the lungs we call that the pleural membrane. So we got a visceral pleura and a parietal pleura. And inside the lungs, inside that pleural cavity, we have a suction that gets created. And so that's very interesting, because the intrapleural pressure inside there, the suction inside there, is greater than the suction we get from the atmospheric air. So the pressure in the atmospheric air is a little bit different. And that creates that ability for the lungs to attach to the chest wall. And as then the chest wall moves and we breathe in and out, the lungs expand with the chest wall. And so the lungs in itself don't breathe. The lungs are passive. They just fill up with air and they let go of the air. What actually does the breathing, what we call the breathing, so to speak, is the chest wall that raises when we inhale, and that collapses sort of a little bit when you exhale. So the lungs follow the inspiration movement of the thorax. If we get an injury and we get something stabbing, like a rib that breaks, or a knife or some weird object that we don't like in there. But if we get a connection between that intrapleural space, that space between those two membranes, and the outside, the atmospheric pressure or atmosphere, then that suction gets unsuctioned, and air goes in between, and the lungs collapse. And we call that a pneumothorax, and you see that on this picture right here. Up here, pneumothorax. What we can do there, we can introduce an object, we can suction it back up, and we can bring the lung back up, because at the moment of the pneumothorax, this part of the lung is not functioning, and that's of course the problem. We don't like that. So that's why the serous membrane system is particularly crucial for all the organs, but the lungs has sort of this double function. And that brings us to the lungs. The thoracic cavity on each side of the mediastinum, that's the middle part of the thoracic cavity where we have the heart in, is filled with a lung. They are bound below by the diaphragm, and their apices, their tips, superiorly reach above the first rib. So that you got to visualize that. That's actually a big deal, because you see this here on the picture. This is the clavicle. This is your collarbone. And the ribs, I mean the lungs go above the collarbone. So when you go above the collarbone into that divot there, and it, you know, medially towards the neck, you have lung going all the way up to there. The right lung is divided by two fissures. Here's the right lung, two fissures, a horizontal fissure and an oblique fissure. And that makes it three lobes: a superior lobe, a middle lobe, and an inferior lobe, a lower lobe, or an inferior lobe. And the left lung, because we got the heart there, like here's the shape of the heart in here. The left lung only has two lobes. We have an upper lobe and a lower lobe, and we have a oblique fissure only there. We don't have a horizontal fissure, just an oblique fissure. That's fine. Each lobe then is further divided on the inside into pulmonary segments. And those are very important landmarks. If you see here, these colors here, these are all the pulmonary segments. These are important landmarks for radiology when we want to see what's going on, but then also for surgery when we want to do a procedure, we can figure out and identify which pulmonary segment is something in that we don't want, or which one do we have to do something with. On the mediastinal side, that's the medial side, that's towards the heart. There, on each lung there, we have the root of the lung, and that is a place where we have blood vessels as well as nerves and bronchi enter and exit the lungs. And that place is called the hilus. So the place where the vessels go in and out is the hilus. And then we get to the alveoli. And alveoli are the smallest little air sacs here, and those are the site of gas exchange. And so that's our external respiration. That's now the place where the air, the oxygen part of the air, goes from the atmosphere to the blood system. So the external respiration. So when we look at that a little bit more closely, see down here, you can see that. This is a good picture right here. Branches of the pulmonary artery. So the pulmonary artery is the artery leaving the heart with not enough oxygen in it, but it's still an artery because it's leaving the heart. That follows, the pulmonary arteries follow the bronchial tree to the alveoli, where a network of capillaries facilitates the gas exchange by picking up oxygen and releasing carbon dioxide. So these little clingy capillaries here, these red bluish things, are very closely working together with these grape-shaped alveoli. And when you cut it, you see it right in here. The air comes in here, the oxygen, and then from here it goes into the capillaries and then back to the heart. And then those are then pulmonary veins. So these are actually red now because they are carrying oxygenated blood back to the heart. And then we got a separate network of lymphatics that drain the lungs. It's like everywhere else in every other system, where the lymphatics help the drainage. And the lungs themselves, they also need food, they also need oxygen, they need energy as well. But they get supplied by a separate vascular network, not by this vascular network. That's the same thing with the heart. You're going to have the organ itself not get fed with a different vascularity than what's the transport of the blood itself. Ooh, go a little fast. Not that fast. Not that fast. Ventilation of the lung. So now we have a rhythmic breathing allows oxygen-rich fresh air to reach the alveoli, and oxygen-poor, which is carbon dioxide rich. You know, we can do these role plays, and sometimes they do that. but we have this oxygen poor air leave the alveoli. Breathing is accomplished when the lungs follow the movement of the thorax. So we already talked about that before. And that's due to the intrapleural pressure. That's the reason why the lungs can be attached and suctioned to the thoracic wall and then follow the movement of the muscle of that wall. And when we do that movement, actually the most important muscle is actually the diaphragm. The diaphragm increases the chest cavity volume by moving downward, by moving inferiorly, and then the other muscles that work together with that is the external intercostals, which are the ones here between the ribs on the outside, and they actively elevate the thorax. And then changing the lungs volume changes the intrapulmonary pressure in relationship to the atmospheric pressure, and in this way, this is a complicated way of explaining how air is sucked into the lungs during inspiration and then expelled during expiration. So the intrapulmonary pressure, this word down here, intrapulmonary pressure, that refers not to that intrapleural pressure that was in between those membranes. This is now the pressure on the inside of the lungs. And for a brief moment, if you will keep your mouth closed and your nose closed and you expand the chest wall, that inside the lungs pressure is below the one on the outside. And as soon as you open those passageways, which they're always open, hopefully, the air just flows in passively because it wants to flow from a higher pressure area to a lower pressure area. Again, with passive movement, it always wants to go from a higher something, concentration of something, to a lower concentration of something. So that's what you have right there. That's the complicated way of explaining that. If we need to bring more air in, if we need a forced expiration, we have accessory breathing muscles that further increase the chest's volume. So we get these muscles up here. For example, we get the neck muscles that lift up the chest a little bit more and that bring it up. We can even bring the arms out a little bit more and expand it laterally a bit more. When you expire, we simply relax the diaphragm and the chest wall returns mostly through passive recoil to the resting position. We can forcefully expire, and we aid that by compressing the rib cage further because we've got internal intercostals that push the rib cage downward, but we also can compress the abdominal content and further decrease that chest wall A to P, anterior to posterior. So we can do that.